Okay, so I'll pick an easy one for you actually. Yeah, okay, describe this then.
Uh, this looks the AP and lateral view fracture of the distal tibia and fibula, and I think the transverse fracture.
Okay,
Yes, sir.
so what else do you want to know? So I'm the patient, you can ask the history or you can, it's an open fracture, let's put it that way. So if it's an open
Yes, sir.
fracture, how does your
I
management?
will, sir. I will start from mechanism of injury, and later on, the either it is open fracture or closed.
So it's an open
And
fracture.
sorry, sir.
It's an open fracture.
It's open fracture. Okay. I will also assess the distal neurovascular stressors like dorsal spinatus tibialis posterior artery
So
and
everything is okay.
sensory. Then everything, if it is okay, then I will classify it according to Gustilo-Anderson.
Okay,
And
so do you classify Gustilo-Anderson before cleaning up or after cleaning up?
sir, before cleaning up,
No,
I'm not
classification is done after you've done your debridement.
okay, sir.
Okay, so
Yes,
you must start always in a viva like this, is that assuming that this is an isolated injury, ATLS
yes,
protocols have been met, this patient is stabilized, this is an open injury. My first priority would be to take a swab from the wound, take a picture and stabilize it, and take it to theater, further stabilize it. Okay?
okay,
That's what your
okay, sir.
answer should be. Your answer should be that this is assuming that this is an isolated injury. The patient is
Yeah.
less triaged. Okay. I will take a
Yes, sir.
swab from it. I will take a picture of this. I will stabilize this. And assuming there is no contraindication to surgery, I will take this patient for further management. Is that agreed?
Okay, sir.
Okay. So now you've taken this patient to theater. What are you going to do?
Enter theater.
So this patient is an open fracture. You put a plaster in him in the the trauma room or the emergency room or whatever you want to call it. So now the patient is ready for theater. You've taken him. What is your planned procedure for this person then?
Sir, my plan should be after like documentation, photograph, taking culture, and irrigation, and I will splintage, and then I will arrange OT and
Okay, so
shift
now you're in
them.
OT. What consent are you going
Yes,
to
sir.
take from this patient before you take him to OT?
And sorry, sir, I cannot understand that one.
So what are you going to tell the patient? What are you going to do with him?
Yes, sir. I will brief the like procedure that this is an open fracture and it will be stabilized by external fixator, and I will brief that about the surgery like external
Okay.
fixator.
So you want to use an external fixator. Is that what you're saying?
Mm,
You want to use
what
an
I
external
will,
fixator, yeah? You want to use a pin fixator or you want to do a circular frame?
sir, what we do here in this condition, pin fixator, not circular,
Okay. So see,
routinely.
exam situation, it is not what you do in the country, it is what is ideal. Okay. Exam is the ideal world. You answer the question which is the best possible management for this patient. Why would you not put a
Oh,
nail here?
nails are in open fracture uh, should be avoided because in up to the if there is a laceration like 1 centimeter and no contamination is there, and then we
Okay.
can
So,
do
so there is no contraindication to put a nail in an open fracture once you've cleaned and tidied up. That's what evidence suggests. But there's another
oh,
reason for not doing this. Why do you not want to do this as a nail?
seven nails are especially in contamination. The wound is dirty,
That's no
so
contamination. It is not a contaminated wound. You can put a nail in an internal fixate in an open fracture, provided there is no contamination. So there is no contamination here. So why can you still not put a nail in here?
Then, sir, we can do nailing, sir.
Yeah, so that's what I'm asking. What are the reasons why you would be worried to put a nail here besides contamination?
Sir, in contamination, sir,
So
if
don't go
we
back.
put
If you
an
repeat questions in the exam, you will lose points. Okay. So you will not do a nail here because it's too distal and you might find it difficult to lock it.
but
Okay.
there is some space for a single screw if we can
Yes.
do
But
nail.
do you know what the working length is?
The working length is the distance between two screws, like proximally and distally.
No, it's a distance between where the bone is not in contact with the metal that you put in, like a nail or a plate or whatever. Okay. So this looks like a very hollow bone, right? So if you put one screw in there, your working length is going to be between the two screws. So you have to put a bigger diameter nail, or you may be able to put some screws, but you may need more than one screw to put it to make it stable. Okay. It can be done,
Yes.
but it is far better to put a fixator on this. Okay, so let's go back to the classification of open fractures. Once you have taken the patient, you've debrided them, cleaned it up, you will grade the patient into the Gustello classification. Can you remind me what is the Gustello classification?
Sir, then, sir, I have less than 1 centimeter wound, and then it is more than 1 centimeter, and
So the Gustello classification is three types, isn't it? So there's one, type 2, and type 3. And type 3 is then further divided into A, B, and C. So what is type
yes,
1?
sir.
What is type 1?
Type one, sir, less than 1 centimeter wound, and
So in a type
open
1
fracture.
Gustello classification, there's fracture of a bone with a communication to the exterior, i.e. it's an
Uh,
open wound, but less than 1 centimeter wound. Is that right?
yes, sir.
Correct. So type 2?
Type 2, sir, when there is the open fracture communicating with the external environment, and the wound of more than 1 centimeter.
Okay. So what is type 3 then?
Type 3, sir, when there is a wound more than 1 centimeter but coverable. And
It
in
can't be type 3 then,
3B,
isn't it? This is type 2 then. So type 3 is 5 centimeter or more wound with either A, you can cover it, 2, there is a vascular element to it, 3, there is a neurological element to it.
yes, a type 3 with associated with vascular injury.
Okay. So in the exam, you will always say that type 1 is a wound that after debridement, it is less than centimeter and is communicated externally. Okay. You must always use the word after debridement because you can only classify them after you've cleaned and tidied them up.
Okay, sir, after debridement.
So what is a mangled extremity severity score? MES. What's the MES?
Mangled extremity score is, sir, depends on 4 things: the shock and hypotension and
So what's the
wound.
difference between shock and hypotension?
What is?
Difference between shock and hypotension.
Yes, sir. Hypotension, sir. If hypotension is
So
respondent to
let's go back again. You must be very clear in the exams because the examiners are very ruthless. They're not there to teach you. They want to know how much you have learned. Okay. So mangled
yes,
extremity severity score is a scoring system to guide us in crush injuries whether the limb is salvageable or not. Correct?
yes, sir.
Okay. So there is a criteria for assessing that, and the criteria is depend on the time of the injury, the relative blood pressure of the patient, the oxygen carrying capacity, and the ischemia, relative ischemia time. Is that correct?
Yes, sir.
Okay, so you must know these all very clearly when you ask the question because the examiner will not teach you in the exam. He will expect you to know all these things. And in Pakistan, open injuries and mangled extremities are very, very important topics to know. So you must go home, learn these, and completely remember them and be able to reproduce them on the day. Yeah.
Okay, sir.
I want to show you something else now. Okay, so this patient, that was done. Are you happy with this?
Sir, fracture is not well reduced, and if it is done for the only wound management, and later on it will be definitely fixed when wound will
Okay.
be
So
happen.
if you do it for wound management, you've got pins in there. There is a high chance that whatever you do in the future will get infected. So this fracture has not been reduced in both coronal and sagittal plane. You can look at it,
Yes,
not reduced. So this is a very poor correction. Okay. Do
yes,
you
sir.
know a method or doing a plan when you have to have difficult fractures and you can't sort them out, or you're not capable of, or you're not having the proper implants for it? How do you manage those fractures then? So if you're in a district hospital which has got no facilities except maybe a fixator, how are you going to manage a difficult fracture? Do you understand the
Now,
word span, scan, and plan? Have you heard that before?
yes, sir.
Okay, what does that mean?
Yes, sir.
What
Yes,
does
sir.
that mean?
Scan, and then plan. So in sir open fracture, if I am in a remote area, so if I have the availability of fixator, I will stabilize by that. If I don't have, then I will apply the back slap, and after cleaning the wound, the debridement, and then I will
So you span it
apply.
first by either plaster or fixator. What does scan mean?
Yes, sir. Scan means sir, if I need some radiological investigation like CT scan, or if I'm in doubt in any
So
fracture
any kind
geometry.
of investigation you want to do that will help you in your management of, or wherever you're sending the patient centrally, then you need to scan the patient. So you have stabilized the fracture, you have done the initial investigation and whatever the patient needs. So we need to know, okay, you've always taken a
Yes,
picture, you've taken a swab from it, and you have done the Gustilo classification. And then when the patient
yes,
goes
sir.
to a tertiary reference center, or when you have time, you can do what is called plan. You can decide that this is what I want to do. I want to nail this. I want to plate this. I want to put a ring fixator. I want to put a pin fixator. So understand?
Yes, sir.
Okay.
Means
So remember,
documentation photograph.
sorry.
Yes, sir. Means after before referring, I should have
Yes.
to take a photograph and document it,
And
then
take a swab.
classify the
Make
fracture,
sure that you take
take
a
a
culture of
swab,
it also. Yeah.
and whatever treatment
Okay.
given, that
So,
should be
so
mentioned.
let's revise this again. In the exam, when somebody shows you an open fracture, the answer is, assuming that this is an isolated injury, there is no contraindication to surgery. The ATLS protocol is triage, is done. I will span this fixator, stabilize the patient. I will do some x-rays, and then I will plan further management for this patient. Okay, this is the answer you give to the examiner. When you give this answer to the examiner has got no choice but to move on to the next question. Okay, so the
Okay.
big question for an open fracture, you must know Mengel ischemity severity scoring MES. You must know this because this is how you decide whether the limb can be salvaged or not.
Yes, sir.
So we agree with that?
Yes, sir.
Okay, so that's very good. So does anybody else now want to volunteer? I can show you some pictures. Who else wants to play now? So Eunice, do you want to play?
Yes, sir. This is the looks the supracondylar fracture, sir, and
Okay.
but I cannot comment on the either it is intra-articular or not because
It's
X-ray.
not an open fracture, it's a closed fracture, but it's a
Yes, sir.
supracondylar fracture. Okay, the supracondylar fracture, you must know that this is a young person. You can see physis. Can you see it?
Yes, sir.
Okay, so it's in a young person. So it's not an adult, so you don't want to know whether it's intra-articular or extra-articular because in children, the fracture is always closed and it's always just above the articular physis, yeah?
Yes, sir.
Okay, so what type of fracture is this?
Sir, this is I think extension type injury, and it is type 3.
Okay, so in the exam, never mention 1, 2, or 3. You will say that this is a extension type of injury. It's a Gartland fracture, and it looks like it's totally off-ended, so it's a type 3. Okay, this is how
Okay,
you.
the Gartland type.
Okay, so
Gartland, I should
you know what a
use
Gartland
word.
type 4 is?
Yes.
Do you know there's a 4 in a Gartland?
Sir, I have read that, but I forget.
So Gartland 4 was modification, and when you are manipulating this patient and it is completely unstable, i.e. there is no periosteum left on it, when you're trying to fix it or manipulate it, then it becomes a Gartland 4. But you cannot do a Gartland 4 unless you take the patient to manipulation. So, like the Gustilo classification, 1, 2, and 3 are done before the procedure, and type 4 is done after you've taken the patient to theater. Okay? So, how will you manage this patient?
Sir, history, mechanism of injury, and clinical examination, like
so what's important in
assessing.
history? What do you want to know in history that will make a difference in your management?
So, mechanism of injury, how child got, and excluding other injuries if this is only isolated injury, and
Okay,
open.
so in the exam, again, the answer is exactly the same thing. Assuming that this is an isolated injury, ATLS protocol and triage has been done, this patient is stable and is fit to have an operation, there are no contraindications surgery. My plan of management for this patient is, okay, this is how you will start all your trauma questions, answers.
Okay, assuming this
now you tell me in the exam, I will take history, I will do, this means that you are telling me what a medical student is going to tell me. You are now not a medical student. You are a postgraduate student who is doing the highest exam in your specialty. You cannot be like a medical student, tell me I will take the history, I will examine the patient. No, because yes, you can do these things, but you should not spend time on those. You need to show your knowledge to the examiner. So again, this is a supracondylar fracture, an extension type, possible Gartland 3, assuming that this is an isolated injury. There is no contraindication to surgery. The patient has been ATLS triaged. My plan of management for this patient would be, okay, this is what you say. So what is your plan of management for this patient?
My plan of management would be, sir, close reduction and percutaneous pinning.
Okay, so are you always successful in doing a close reduction?
No, if I fail to reduce the fracture,
you
then
cannot say that
I will
do a close reduction. What you will say, I will attempt a close reduction and fix it with KYs to stabilize it. Okay?
Okay, sir.
So, Angrezi language का भी खेल होता है इम्तिहान में. Not just because you know, but you have to tell them.
सर लेकिन पहले तो हम वो ही बताना चाहें ना ऑप्शन के, मतलब क्लोज जो बेटर है ज्यादा, तो
पर अगर आप अगर मैं आपका एग्जामिनर हूँ, आप मुझे कहेंगे कि क्लोज इसको मैं फिक्स करूंगा, तो मेरा नेक्स्ट क्वेश्चन ये होगा, अच्छा ठीक है आपने क्लोज फिक्स नहीं किया तो क्या करोगे?
जी सर, अगर क्लोज में कोई इंटरपोजिशन सॉफ्ट टिश्यू आ जाएगी तो फिर हम जो है इसको ओपन करके उसको
कहाँ से ओपन करोगे? Where do you open it?
सर इसकी पोस्टीरियर अप्रोच सर हम जो यूज करते हैं ट्राइसेप को स्प्लिट करके.
अच्छा, is that recommended? Is that written anywhere?
Sir,
so what about the nerve? There is a big, huge nerve there, and you're doing a posterior approach. आपकी nerve को क्या बनता है?
सर नर्व को तो इनिशियली सेव करेंगे, अल्ना नर्व को आइसोलेट करके और उसको स्लिंग लगा के
ऊपर से नीचे तक उसको खोल दोगे. So always, you know, the recommended approach for this, which is written and evidence-based, is you will go medially first. You will find where the nerve is and isolate the nerve.
Medial, sir.
Chota sa small incision there, medially. Find the nerve.
Yes, sir.
And then you put your finger in front of the fracture under the brachialis and reduce the fracture. Pull it back and reduce it after you reduce it partly. Then put a wire from the medial side or the lateral side and stabilize it, and then put wires on both sides then. Okay?
Okay.
If you have to open it, you have to save the nerve. You cannot
yes, sir.
Use it open when the nerve is in the way.
Yes, sir.
You must always look for the nerve before you try to fix it.
Yes, sir. First safety of the ulnar nerve.
Exactly. Okay. अच्छा, अगर इस patient को जो है ischemia हो गया है and the patient has got no pulses, what are you going to do then before you start?
So ischemia हो गया है तो वो सर टाइम
pulseless
hand है, तो सर फिर टाइम पीरियड पे डिपेंड करता है. इनिशियली तो हम फ्रैक्चर को रिड्यूस करेंगे, रीअसेस करेंगे कि पल्सेशन रिटर्न हो रही है.
Try to reduce the fracture and reassess the perfusion. What is the most important thing you have to do before you try to attempt the fracture as an emergency?
So attempt करने से पहले क्या मतलब करेंगे हम?
You must always must always know how to look for the vessel or ask your vascular surgeon colleague to give you a hand.
जी सर,
अगर
मतलब ऑन
वेसल
बोर्ड
आपकी
उनको।
डैमेज हुई है तो या तो आपको रिपेयर करना आता हो या किसी वेस्कुलर सर्जन को साथ बुला के रखें बिफोर यू ओपन इट.
जी सर,
ओके.
वेस्कुलर सर्जन ऑन बोर्ड हो।
Yes, otherwise you're going to miss out on the most important part of it. अच्छा, आपने इसको, you now reduced the fracture, you fixed it, and the vascular pulses come back again, and you stabilize the fracture. What is the next thing you're going to do?
सर सर हम फिर रीअसेस करेंगे डिस्टल
I've just
वेस्कुलरिटी
told you after
कैपिलरी।
you reassess, you've reassessed it, the patient vascular, the pulses are back, everything is fine. What are you going to do now?
सर बैक स्लैब 90 डिग्री पे लगा
You've
के
done that.
एलिवेट।
Before that, what are you going to do then? आपने 2 बार डाल दिया, उसको स्टेबलाइज कर दिया है, वेसल्स उसकी वापस आ गई है, आपका फ्रैक्चर बहुत अच्छा लग रहा है. व्हाट इज नाउ यू गोइंग टू डू? व्हाट इज कॉल्ड प्रोफिलैक्टिक डिकम्प्रेशन. वो कंपार्टमेंट सिंड्रोम की प्रोफिलैक्सिस के लिए इनके फिशियोटॉमी करते हैं.
जी सर, अगर वो
Every time you have a supracondylar fracture which has got no pulses or relatively pulseless, when you do any kind of surgery, just pure fixation or whatever, and when the pulses come back, there is a high chance of reperfusion injury, and because of reperfusion they have edema and they end up with compartment syndrome. अगर किसी भी limb में vascular injury हो which has been fixed, you have to have a prophylactic fasciotomy for these patients.
प्रोफाइलेक्टिक फिशियोटॉमी। जी सर।
If you don't do it, they will all end up with compartment syndrome.
सर वो तो हम फिर उससे जब रिड्यूस करने के बाद अगर वेस्कुलरिटी आ रही हो, कैपिलरी रिफिल आ रहा हो, तो फिर तो हम नहीं करेंगे ना सर।
So when you don't open the patient, you have manipulated the patient and it has become stable and the vessels come back. No. But if you have opened the patient to get the vascular perfusion going, to reduce the fracture and all that kind of stuff, you will have to do fasciotomy because reperfusion injury will cause free radicals. Free radicals will cause cell destruction, which will cause edema, which will cause compartment syndrome.
Okay, sir.
Okay. So can anybody else now participate? Because Yunus साहब के साथ बहुत ज्यादा हो रही है, सारे सवाल उसी से पूछे जा रहे हैं.
Sir,
who wants to play? Con. There's about 7 of you here, isn't it? 6 of you. Can anybody else play? Badr Saab, do you want to play? Zahid Saab, Badr Saab, Shahbaz Saab. कोई है? Does anybody want to volunteer? See, exam जो होता है ना, उसका तैयारी इस तरह होती है कि आपने सवाल पहले से तैयार किया हुआ होता है उसका जवाब. So if you discuss, the more you discuss, the better you're going to get. So this is not an exam, this is practice. We have 3 months. Hopefully by 3 months you will all be good. So I can't force you, but the more you participate, the more you talk, the better you're going to get in the exam. अब यूनुस साहब से अगर सुप्राकॉन्डिलर फ्रैक्चर पूछा गया और ओपन फ्रैक्चर पूछा गया तो उसको फिर तकलीफ नहीं होगी. यूनुस साहब will do it fair. So you guys need to participate.
Yes, sir.
It's not a difficult. Sorry.
Yes, sir. वाइवा के लिए तो है ही, मतलब थोड़ी डिस्कशन और जब तक बोलेगा नहीं तो
जब तक लफ्ज नहीं मुंह से निकलेंगे जब तक एग्जाम में फायदा नहीं होता है. You cannot replicate an exam unless you practice.
तो यही मैं भुगत चुका हूँ अभी वाइवा में.
बोलना जो होता है ना बहुत जरूरी होता है, बहुत जरूरी होता है. You have to talk before you go to the exam. So does anybody want to play? Nobody wants to play. Okay, let's make it simple then. Okay, this one then. You didn't want to play with a Miss Frank injury, so this is a tibia fracture. Come on, guys.
Yes. Schatzker type 2.
So who's speaking now? Sorry.
Sorry, sir.
So who's talking to me? I don't know.
Oh,
no. Are you still talking, Yunus?
Yes, sir.
Okay, go on then. Not? Nobody wants to play. You're the only one today.
Yes. It looks as a Schatzker fracture of the tibia.
इस तरह एग्जाम में नहीं शुरू करना है, बड़ी खिंचाई होगी. So can say this is an X-ray of a mature, skeletally mature adult showing the knee joint, and in the knee joint shows fracture of the tibia. Okay.
Okay, sir.
Right.
X-ray of the skeletally mature patient and showing the fracture of the proximal tibia and Schatzker type separation भी लग रही है सर इसमें. Type 6 लग रहा है.
Bicondylar fracture, isn't it?
Bicondylar.
Bicondylar देखो ना, एक ये हो गया और एक ये हो गया, bicondylar हो गया ना.
सर ये एक मेटाफाइसिस से ये फ्रैक्चर लाइन इधर भी मुझे थोड़ा शक पड़ा.
It's coming here, it's bicondylar. यहाँ भी जा रही है. Okay,
ओके
so
सर, bicondylar.
Yatzker ने जब अपना पेपर लिखा था तो कितने मरीज से टोटल जिस पर उसने क्लासिफिकेशन बेस की थी?
सॉरी सर, ये यार
टोटल उसके पास थे 17 मरीज. 17 मरीज पे उसने 6 क्लासिफिकेशन डाली थी. पूरी दुनिया उसको फॉलो करती है. And it is only based on 17 patients. अगर उसने 20 मरीज पे 25 देखे होते तो हो सकता है कि उसकी क्लासिफिकेशन 10 होती या 8 होती या 9 होती. तो उसने जितने मरीज देखे थे उसके बेस पे किए क्लासिफिकेशन. What is the
तभी सर ये
classification?
व्हाट है सर?
What is the importance? हमारे को क्या फायदा होता है क्लासिफाई करने का?
सर क्लासिफाई करने से एक तो हमें डॉक्यूमेंटेशन है, प्लानिंग ऑफ द ट्रीटमेंट है.
How does it help in planning?
प्लानिंग सर इस सेंस में कि हमें फ्रैक्चर ज्योमेट्री पता चलती है, तो
So
उसके
it is
बाद
basically
हम
about communication. So when you communicate with people, people will know what you're saying. Okay, that's what it is: documentation and communication. To classify the patient, it should help in management of the manage of the patient. It does help in management of the patient, but it does not tell you what is the long-term outcome if you do what you're supposed to do. Okay, is there any other classification? No, of tibial plateau fractures.
यस सर, हॉलैंड मोरे ने भी एक क्लासिफिकेशन बताया कोरोनल प्लेन में, लेकिन
Chinese classification, which classify this into zones. There is there's a posterior zone, there's a medial zone, and a lateral zone. Okay, you must go and read that because that is what is getting more common now in Europe, at least, where they talk about the 3 different zones. So this tells you what approach you're going to take and how you're going to manage these. If it's a posterior lateral compartment, it's a posterior medial compartment, or it's posteriorly based compartment, it will tell you what to do. This does not tell you what approach to take, it just tells you how to classify. Okay, so coming back
what
to
the name for that, what the name for that classification?
I don't remember, but there is a Chinese classification which tells you on the compartments, front, back. Basically, एक बड़ी posterior compartment होता है, एक medial, एक lateral होता है उसके अंदर. How are you going to manage this one?
So, if assuming that this is the only isolated injury, or assessing the distal neurovascular status, like in this kind of fracture, we have the risk of compartment syndrome, and so I will first exclude that by assessing distal pulse sensation, and then I will advise for it has been done.
Okay.
CT
so
scan.
we've already discussed an open fracture. This is something similar. Okay. So what we're going to say is that assuming that this is an isolated injury, it's a closed injury, there is ATLS triage has been done, there is no contraindication to surgery. Depending on my skills, I will either do a temporary stabilization or do a more permanent procedure. My plan would be to span it, scan it, plan it. Okay, in my planning, I would preferably use a fixator of a frame, something like that. That will help me because इसको आप metal से नहीं fix कर सकते क्योंकि उसको कहते हैं double bone sandwich, double metal bone sandwich. दोनों तरफ से metal डालोगे उसको avian होगा, you won't know.
Yes sir, skin excoriation हो सकती है.
Everything. Remember, answer is the same. हर question में trauma में answer is the same. Assuming that this is an isolated injury, the patient is ATLS triaged and stabilized. There are no contraindications to surgery. My plan of management for this patient would be to span this, scan this, and plan it. अगर उसके बाद examiner आपको कहेगा कि ये जो है आपको permanent क्या इसको treatment करोगे, then you say I will put a ring fixation here or something like that. जो आपके G में आएगा उसको कह दीजिएगा और then justify. Okay. But today, I'm going to show you only simple things so you know how to answer. आहिस्ता इसको depth में जाएंगे, but today only how to answer a question. Is that correct?
Okay, sir.
Okay. So my picture is not going from, I've made a line for some reason. Oh, there you go. Yeah, that's your MES injury. Remember when we were talking about MES?
Yes, sir.
This is how this was planned.
MES,
Okay, so you need to know what MES is basically.
MES is closer.
You have to know it for the exam. Okay.
Okay, sir. I will read it again.
Find you a nice one. Okay. Can anybody else try? Because Yunus साहब से बहुत जाती हो रही है. कोई और volunteer नहीं करना चाहता? There's quite a few of you here. Why don't you all try?
आ जाओ दोस्तों, आ जाओ, कोई मसला नहीं. सर इतना पढ़ा रहे हैं आपको.
और ना मैं किसी को साथ शोर शराबा करता हूँ ना मैं तंग करता हूँ. मेरे से ज्यादा बेहतर एग्जामिनर आपको नहीं मिलेगा. एग्जाम वाले तो बड़ा बदतमीजी करते हैं और बड़ा तंग करते हैं.
आना चाहिए दोस्त, पता नहीं क्यों घबरा रहे हैं.
अभी मैं गया था पाकिस्तान. वो लियाकत नेशनल में मीटिंग थी तो वहां पे मेरी जकी साहब से बात हुई थी. तो
जी सर.
प्यारे भोले आदमी है. मेरे काफी अर्से से जाते हैं लेकिन एग्जाम में वो बड़ा तंग करते हैं लोगों को.
हाँ, तो जकी साहब का खौफ रहता है दो लड़कों को.
तो वो तो लिहाज नहीं करते हैं. वो इसलिए तैयारी पूरी होनी चाहिए क्योंकि वो चाहते हैं कि सबको सब कुछ आना चाहिए. एनीवे, एनीबॉडी वांट्स टू गो? कोई और फाइनल ये करते हैं फिर देन आई हैव टू गो.
जी सर.
चलिए यूनिस साहब आप भी देख लें. बाकी सब तो गायब होने के चक्कर में.
Sir, X-ray of the skeletally mature patient showing the wrist joint, and there on commenting on the wrist joint, there looks the perilunate dislocation on the lateral view.
Very good. So this even on the AP you cannot see the lunate. Okay, so normally the wrist doesn't look like that. There's a big huge lunate here, so it looks like a perilunate dislocation. You can see now the lunate, and you can see the capitate here. So it's a perilunate dislocation. Yeah.
Ji sir.
So do you know how you're going to manage this? Now you have to give me the right answer because you're choti baar ho gaya, Yunus sahab.
Ji sir.
How you going to manage this?
Sir, after assuming this is the only isolated fluid.
Assuming नहीं कि आपके कहना है कि assuming that this is an isolated injury, the ATLS triage and protocol has been carried out. This is a closed injury. There is no contraindication to surgery. My plan of management will be ये जवाब देना है इम्तिहान में जब भी आपको किसी सवाल का मैनेजमेंट प्लान पूछे.
ओके सर, मैं इसको थोड़ा पक्का करता हूँ जबान पे लाऊंगा.
So क्या करोगे perilunate dislocation के साथ? What are you going to do?
Perilunate तो सर I will try to मतलब कभी.
So this is an emergency. You have to take the patient to theater as soon as possible. Yeah.
Yes, sir.
You will try and to close reduce it.
Closely reduce, but
if it doesn't reduce closely, you have to open vorally or dorsally.
Sir, dorsally.
Because you have to reconstruct the ligaments.
Yes, sir. Dorsally खोलेंगे क्योंकि वो.
But if it doesn't work, you can also open vorally. You can open both sides. Okay. But try to open dorsally and see if you can reduce it. Once you've reduced it, you will hold it after repairing the scapholunate ligament because that's the key. If you don't reconstruct the scapholunate ligament, it will be unstable, and you will hold it in KYs.
Yes, sir.
Okay, and then put in a plaster and manage this. Okay.
Open relocation, reconstruction of scapholunate ligament, and holding with the K-wire and plaster.
So, do you know how the perilunate होती है या transcaphoid perilunate होती है? कैसे होती है ये? What is the mechanism? What is the principle for it?
Sir, transcaphoid में through scaphoid से shearing forces fracture करती हुई जाके और उसके साथ ये dislocation भी हो.
So what is a Mayfield circle then? Do you know?
Sir, Mayfield ने भी ये ligaments पे ही उसकी rupture की मुझे वो exact इस वक्त याद नहीं आ रहा.
So you start from medial and you come back to middle again. बड़ा circle बनता है. Depends on whether it goes through the scaphoid or above or below it. You get the transcaphoid. You must know the Mayfield. Yeah. Mayfield is a circle. उसने describe किया था कि कहाँ से start होती है और कहाँ खत्म होती है. And depending on where it finishes, that's what you get a perilunate or a transcaphoid perilunate dislocation.
ये सर वो ग्रेजुअली लिगामेंट्स के रप्चर पे ही
तैयार होते हैं जी. Okay, so once you go and revise all these things, and hopefully इंशाल्लाह अब कोशिश करेंगे कि हर संडे को 1 घंटे के लिए बैठ के ना थोड़ा सा रिवीजन किया करें.
जी सर, अभी मैं शुरू करूँगा. जी सर.
But we need to participate. एक आदमी को पढ़ाने के लिए नहीं, मैं इंग्लैंड से सुबह उठने के लिए नहीं आया हूँ. सब लोगों को पार्टिसिपेट करना है, सबका फायदा होना चाहिए.
जी सर, सब दोस्तों को पार्टिसिपेट तो करना चाहिए. सुनने से नहीं है भाई मेरे, थोड़ा खुद
एग्जाम में जो है ना सुनने से कुछ नहीं होता है. You have to say and you have to learn how to say. अगर वहाँ पे बोलोगे नहीं ना, फर्स्ट टाइम बोलोगे तो बड़ा प्रॉब्लम हो जाएगा.
हाँ सर, ये मेरी तो खुद की जो है अभी इतनी प्रैक्टिस नहीं है, तभी आप खुद देख रहे हैं मुझसे खुद से गलतियां हो रही. यही वाइवा में भी मुझसे हो रहा था.
देखो जो एग्जामिनर्स है ना, सब बड़े शरीफ लोग हैं, बड़े तमीजदार लोग हैं, बड़े पहुंचे हुए लोग हैं. इन सबसे मैं जानता हूँ पर्सनली, मेरी सबकी इज्जत करता हूँ. लेकिन एग्जाम वाले दिन वो किसी का लिहाज नहीं करते हैं. ना वो भाई को देखते हैं, ना वो बेटे को देखते हैं, ना वो बाप को देखते हैं. एग्जाम वाले दिन
हाँ
सब
सर,
एक ही छड़ी से आंकते हैं.
हाँ
नॉलेज
सर, बिल्कुल. बहुत
नॉलेज नहीं होगी
सिंपल पूछते हैं जैसे आप बता रहे हैं ना सर. वो तो क्वेश्चन तो इतने वो सिंपल होते हैं, लेकिन हमें उधर शायद सही से बोलना नहीं आता, वो हमारी प्रैक्टिस नहीं होती.
नहीं, मैंने इनके बात की है. एग्जाम के क्वेश्चंस कोई डिफिकल्ट नहीं है पाकिस्तान वाले, सिर्फ हमको तरीका नहीं आता
जी
जवाब देने का. दैट इज द बिग प्रॉब्लम. छोटी छोटी बातों
सही
पे
कह
हम
रहे
पहले जाते हैं. जैसे फॉर एग्जांपल वो जो सुप्राकॉन्डिलर फ्रैक्चर में दिखाया था, सबसे इंपॉर्टेंट चीज
हैं.
हमें
जी
ये
सर.
बोली थी कि ये जो स्केलेटली मैच्योर बंदा है, यानी यंग पर्सन है. अब सुप्राकॉन्डिलर फ्रैक्चर जो एल्बो का होता है ना, उसकी मैनेजमेंट चिल्ड्रन में अलग होती है, बड़ों में अलग होती है. लेकिन अगर आप
जी
एग्जामिनर
सर.
को यही ना बता सकें कि ये बच्चा है, ये बड़ा है, तो फिर आगे कहाँ जाएगा एग्जाम में. वो वही आपका घंटा उसी में ज़ाया हो जाएगा पूछने के लिए कि बड़ा है, छोटा है, छोटा है, बड़ा है. इसी में टाइम ज़ाया हो जाता है.
यस सर.
चलें जी, इंशाल्लाह फिर अगले हफ्ते इंशाल्लाह मुलाकात होगी. लेकिन अपने दोस्तों को कहें कि आए पढ़े. मतलब
जी सर, मैं अभी उनको भी बोलूंगा, अभी 2-4 जो हैं ज्वाइन मेरे साथ.
चले ठीक है जी. ओके.
नेक्स्ट वीक सर क्या टॉपिक?
व्हाटएवर टॉपिक यू गाइस. मैं तो कोई तैयारी करनी पड़ती नहीं है, मेरे पास स्लाइड्स पड़ी होती है. बातचीत तो आप लोग करते हो, मैंने सिर्फ स्लाइड दिखाई होती है. व्हाटएवर यू वांट टू टॉक अबाउट नेक्स्ट टाइम फिलिक्स की बात करें तो.
जी सर.
चलो
या
ठीक
तो
है. बट
पेल्विस और एसिटाबुलम.
तो इसी क्वेश्चंस को रिपीट भी करते रहेंगे ताकि एग्जाम वाले दिन जो ना पक्की हो जाए.
जी सर. जी सर.
Okay.
पेल्विक फ्रैक्चर, एसिटाबुलम, लाइक इन पे थोड़ा.
हाँ, वो मैंने पहला एक्सरे एस्टिबल था. मैंने कहा कि पहला वाला जो है डिफिकल्ट नहीं शुरू करें, आसान आसान से पहला हफ्ता जो है गुजार दें, फिर आहिस्ता, वरना को आप सब डर जाओगे, फिर दोबारा कोई नहीं आएगा.
सही सर. थैंक यू सर.
चला फिर अगले हफ्ते
थैंक यू.
पुट द पोस्टर फॉरम इन दिस. ओके.
ओके सर, थैंक यू.